Hi everyone, I did my journal review on juvenile rheumatoid arthritis. The article that I picked for our project is a little bit different than the case studies and the experimental studies that we have been reading so far in the program. I picked a review study, and it's a review article from Southern Medical Association titled Juvenile Rheumatoid Arthritis, Physical Therapy and Rehabilitation. And basically, it compiled results from multiple studies to summarize typical PT treatment for patients with JRA, or juvenile rheumatoid arthritis. While reading the article, I noticed a couple of studies quoted multiple times, so I listed two of them for you so that you can better understand the subjects in their studies. The first one is an article from the Journal of Arthritis Care and Research, and they investigated the effects of an 8-week, 24-session weight-bearing physical conditioning program on the signs and symptoms in children with chronic arthritis. They had 25 subjects in the study between the ages of 8 and 17 years old, and their results found significant improvement in pain, aerobic endurance, and joint sign and symptoms. The second article was from the Journal of Pediatric Psychology, and they studied the effects of massage therapy versus relaxation therapy for children with JRA. In their study, they had 20 subjects between the ages of 5 and 15, and their results found improvement in anxiety and stress and pain relief with massage versus relaxation massage. Throughout the rest of this PowerPoint, I'll be sharing the methods and conclusions that were made based on these two studies and the numerous others quoted in the review article. So what is juvenile rheumatoid arthritis? It's one of the most common chronic diseases in children, and it is the most common rheumatic disease in childhood. It's considered juvenile if the onset is before 16 years of age, and the arthritis must be present in more than one joint, persist 6 weeks or longer, and exclude other forms of juvenile arthritis. It's classified as joint inflammation and stiffness, and it triggers a pretty vicious cycle that many times ends in joint damage and chronic deformities. Growth retardation is often seen in children with JRA and even osteoporosis. For JRA, treatment takes a multidisciplinary approach. Children with JRA often seek treatment from pediatric rheumatologists, physiatrists, physical therapists, occupational therapists, psychologists, and even dietitians. So what is the objective of PT for JRA? Physical therapy's purpose is to help restore the loss of function and prevent permanent handicaps. We work on controlling pain, minimizing inflammation, and maintaining and improving muscle strength. The goal is to preserve the functional capacity and autonomy of the child. If JRA goes untreated, permanent deformities can quickly occur during the child's regular growth cycle. So these children tend to tighten their joints into positions that are more comfortable. When they do this, the joint volume is at its max, and any swollen components in the joint are in their most comfortable position, which is often flexion. This leads to flexion contractures and weakened extensor muscles. And as a result, full extension becomes difficult, and then there's a loss of function and limited range of motion. To further complicate that, compensatory contractures occur over time, which limit the function even more. And what's even more is these children are tired and stiff and in pain, so they're less active than their peers, which can lead to systemic muscle weakness, decreased flexibility, cardiovascular reserves, and exercise capacity. So as PTs, you should also put a heavy emphasis on prevention because it's less painful, expensive, and time-consuming to prevent these contractures, muscle weakness, osteoporosis, and disabilities than it is to treat the symptoms after the patient has already developed the problems. So throughout the review article, they mentioned the methods that were examined in the different studies. And over the next 3 slides, I'll share what those methods were. First, we looked at heat therapy. Heat therapy has been shown to decrease the rigidity of joints, increase flexibility of the joint capsules and tendons, and then decrease pain and muscle spasms. The ideal temperature has been found to be between 104 to 114 degrees Fahrenheit and should last between anywhere from 3 to 30 minutes. So PTs and PTAs are suggesting hot showers in the morning to help relieve morning stiffness, warm baths at night for night pains, and hot packs should always be used before exercises, especially stretching. Ultrasound has also been found to be effective for deep heat therapy in the hip, but clinicians should definitely be aware of the growth plates in that area. Cold therapy was shown to provide pain relief and decrease vasoconstriction in inflamed joints during acute periods of pain. It was recommended for use approximately about 20 minutes. However, most children tend to not care for the cold and prefer different treatment methods, even though it is effective. Massage can be shown to relieve pain and prevent adhesions in connective tissues. It should be applied after heat modalities, but before stretching, and this will help maximize the stretch. And because children with JRA tend to hold their joints in flex positions, splinting can be utilized to encourage extension. There's different types of splints, but resting splints are one of the most recommended, and they're to be used during periods of rest to hold that joint in extension as much as the inflammation allows. Because complications from immobilization can occur rather quickly, splints are not meant for children that are on bed rest. And the most common joints that are splinted are the wrist, fingers, and the knee. Lastly, we look at therapeutic exercise. Our treatment should revolve around Therax for children with JRA. It's been proven to decrease pain and muscle spasms, increase active range of motion, and increase strength. Resistive exercise should be limited to 3 days per week, and it must be customized for that child individually. It could include dumbbells, weights, TheraBand, and just activities that they can do that are fun. Aerobic exercise should be moderate in intensity and no more than 30 minutes per day, and stretching has been found to be the most effective to improve range of motion. The stretch should be held for 10 seconds, 5 to 10 times, 2 times per day. And the contract relax technique has been found to be the most beneficial. Children with JRA are encouraged to play sports, but it's recommended that they play sports that do not require excessive use of the ankles. For example, basketball, football, and gymnastics are probably not the best sports for patients with JRA. Here is a list of specific areas that many studies in the review article have found to be the most affected from juvenile rheumatoid arthritis. As you can see, with spine, elbow, wrist, fingers, hip, knee, ankle, and foot, extension is the most common motion to be limited. Therefore, flexion should be avoided and extension should be encouraged. The methods explained in the last 3 slides were taken directly from the studies that the author examined for this review and would help prevent or decrease the limitations listed here on this slide. So is this article a strong resource? I think this article is a really strong resource. Because this was a review article, it provided proven evidence from multiple sources. All of these clinical methods for treating JRA have been backed up by various study groups, control settings, and researchers versus a single case study. Therefore, I find it to be stronger than a case study or an experimental study, and everything that I've listed in this PowerPoint would be helpful to include in our practice for patients that have JRA and even RA.